begin in just a moment. Thank you. Well, good morning, everyone. This is James Giuliano from the Ohio Hospital Association. I serve as Vice President of Quality Programs at OHA, based in Columbus, Ohio. It's my pleasure to welcome you today to our webcast. Our webcast today is entitled Sepsis Care in the Air. It's being presented by a paramedic and a flight nurse, Amanda Wolf, with Survival Flight 14, and she will be addressing the issue of hospital-to-hospital transfer of sepsis patients. As always, when we begin our presentations, we do a little bit of information about our process. And so if we could go to the next slide, please. This slide has the link access for the continuing education evaluation for today's program. By clicking on this link through SurveyMonkey and completing this evaluation after today's program, you will be completing your requirements for continuing education. The link is going to be available for 2 weeks from today. So you do have time to do that. And at that point, you'll be providing your name and email address. Dorothy Aldridge from OHA will then email you your certificate of completion. If you have any questions whatsoever, her contact information is also available on this slide. And we often have questions about whether or not the slides will be available. They will be available, as well as the recording from today's session will be available on our website following today's program as well. We could go to the next slide, please. It is my pleasure at this point in time to turn the floor over to Angelica Estrada of Sepsis Alliance nationally. As you know, we partner with Sepsis Alliance very closely on our statewide sepsis initiative. And today, Angelica is here to talk to us about a very unique opportunity. So, Angelica, I'll turn it over to you.
Hi, can you hear me?
Yes.
Oh, perfect. Okay. Hi, so I'm Angelica Estrada from Sepsis Alliance. Nice to meet you all. So we are right now accepting applications for our Aaron's Campaign for Kids Nursing Awards. These are national annual awards that we give out. And we are accepting applications from pediatric nurses dedicating to improving sepsis outcomes for patients, and as well as sepsis coordinators who are also dedicated to improving outcomes for sepsis patients, and nursing students who are focusing on that. So please apply, encourage the sepsis coordinator in your organization, who's just going above and beyond to apply. Or, if you work with pediatrics, please encourage a pediatric nurse in your system who you feel is really going above and beyond, or who has implemented a sepsis protocol in your hospital organization to apply. The application's pretty easy. It's not very long. And the winners actually do receive awards. So for the pediatric nurse, the award includes a $2,500 grant and domestic airfare for one to New York to attend the Sepsis Heroes Gala on September 12, 2019, where they will be recognized. In addition, they will receive a one-night hotel stay. And the awardee is invited to bring a guest with them to the gala. For the sepsis coordinator, the award is basically the same. The selected awardee will receive a $2,500 grant and domestic airfare for one to New York to attend the Sepsis Heroes Gala on September 12th, where they will be recognized. And they are also, and it also includes a one-night hotel stay, and awardees are invited to bring their guest. If you know a nursing student, who's really involved and interested in sepsis and improving outcomes for patients, we will be giving out 2 awards in this category, and the selected awardee will receive a $1,000 grant. The applications are easy to access. You just need to apply at www.sepsis.org/Erin, which you can see on your screen. On the screen, we have some of our past award winners. And unfortunately, you cannot nominate nurses, but you can encourage a nurse to apply for herself, or a sepsis coordinator. Also for sepsis coordinators, it doesn't have to, the person can be acting in the capacity of a sepsis coordinator, so it doesn't necessarily have to be their title. And I think that's all. Please apply. The deadline is coming up. It's going to be April 26th. We already have some great applications, but we want to be able to get as many as possible and really honor the best out there. That's
well,
it.
Thank you, Angelica, and thank you. And I guess I just want to clarify with you and reiterate that this is, you're asking folks to encourage nurses to nominate themselves. Is that correct?
Yes, they must nominate themselves or apply. Yes.
Okay, great. And thank you for the opportunity and for recognizing the good work of the nurses throughout the state of Ohio, in this. And to me, I know that as you've presented this to us before, that this is more than just an award. It's also recognition of the work that's being done to fight sepsis mortality, which is an awareness campaign as well.
Yes.
So it's very far-reaching, and we greatly appreciate your reaching out to our Ohio cohort with this opportunity. So thank you.
Thank you so much, and please encourage your nurses to apply. Thank you.
Wonderful. At this time, it's my pleasure to turn the presentation over to our presenter. Amanda Wolf serves as the base manager for Survival Flight 14. She is a paramedic by background and also a flight nurse. Amanda has practiced for years in the intensive care unit in a hospital where she cared for sepsis patients over a number of years. And she has also been instrumental in implementing and sustaining the MIST handoff tool in her practice. Amanda is a paramedic who has completed paramedicine education at Clark State Community College. She also holds a Bachelor of Science degree in nursing from Spalding University. It is my pleasure now to welcome Amanda Wolf. Amanda, the floor is yours.
Okay, thank you. Thanks for the introduction. So I'm here to talk to you guys today a little bit about sepsis, and the title of the presentation is Sepsis Care in the Air. That's what we do. We're taking care of you guys with sick patients, transporting them from hospital to hospital. So just want to kind of take you into the day of the life of a flight nurse dealing with sepsis. I want to start though with just what is sepsis. Sepsis was defined formally in 1992 as a systemic inflammatory response syndrome, in the setting of infection. It was later defined also as the presence of bacteria or toxins in the bloodstream that have spread throughout the body. If you look at this slide here, just showing an illustration of someone that's got a probable pneumonia, that infection source goes into the bloodstream. This causes a leaking of the blood vessels, and then this causes a decrease in perfusion, which causes the organ dysfunction, which is what is the end all of what these septic patients are dealing with in our ICUs. I guess also I wanted to talk about the organ dysfunction. These are the patients that have the hypotensive crises such as ATN, acute tubular necrosis in the ICU, end up needing continual renal replacement therapy. So if we can prevent the organ dysfunction and increase perfusion prior to bringing them to you, their mortality is going to decrease significantly. The next slide I have here is the SOFA score. This basically shows sepsis-related organ dysfunction. you can see as the scale moves from right to left, the severity of dysfunction increases. We can assume, therefore, looking at this, if the patient's GCS is, say, a 6, he'll be showing other signs of organ dysfunction, organ failure, such as an increased creatinine and decreased coagulation. So it's interesting to see. I'm going to show you a chart later on from the CMS that shows how they define organ failure and dysfunction. And so it's interesting to compare the two, the SOFA score and then how CMS looks at it. So let's take a look at the difference between hospital and pre-hospital care in sepsis, and then what we kind of deal with on the pre-hospital end of it as opposed to the hospital end. So before I get started with this, I want to tell you a little bit about my background in nursing. I went straight out of nursing school into the ICU in Kentucky. Our ICUs were divided into a medical and surgical ICU, but really it was just whoever had the open bed and available staff. I came to appreciate this, especially once I got in my flight nursing job, because I got a wide range of cardiac, neuro, trauma, post-op, and medically ill patients, and I really thought I was prepared for anything. And then I became a flight nurse, and I went back to being a novice on many things. Different tools and assessment skills are used by pre-hospital staff in comparison to hospital staff. I decided to get my paramedic to help retrain my mind to think pre-hospital and kind of get out of some of that ICU thought, because it is truly a different thought process. So I needed to think like a pre-hospital clinician, and all I knew was critical care nursing. I no longer had A-lines, swans, or respiratory therapists. There were no stat lab values or stat radiology results. There was no physician on the line or in the room with me, and I could no longer have a team of people at my side at the push of a button. So it was it was time to get familiar with what I had to use, and I had to get familiar quickly. So what did I have? I had my assessment tools, right? And that's all we have a lot of times in EMS is what am I looking at, what am I seeing right now, and what is obviously the biggest crisis for this patient. In Central Ohio, we're blessed that our EMS have been provided with criteria to call a sepsis alert to the hospital. There are several pre-hospital screening tools that aid in the decision-making process for EMS so that early sepsis therapy can be initiated. This slide just shows a few of those. There's the Robson. You can see the criteria that they have. I kind of like the BAS 90, 30, 90. I mean, it's down and dirty, quick. Is their systolic less than 90? Is their respiratory rate greater than 30? And are there O2 stats less than 90? So that's a real nice, quick, easy one. And then COTS, Central Ohio Trauma System, has made an amazing sepsis alert protocol. And as you can see here, it is a suspected infection, the systolic less than 90 plus 2 of the following. A heart rate greater than 90, a temp less than 96.8 or over 100, a respiratory rate over 20, and an altered mental status. If you have it as serum lactate greater than 4, and then you have to also have an end tidal of 25 or less. So in talking with some physicians, I kind of feel like when pre-hospital brings these patients into the hospital, it ends up, they call in the sepsis alert, and it ends up stopping and kind of starting over. Whereas, I think a challenge for us as providers in both the field and the hospitals is to develop that trust with each other, that when we're calling a sepsis alert, things can be planned for and prepared for and utilized properly so that that patient truly has a continuum of care instead of kind of having to start the process over when they come into the ER. And that's where the missed handoff that we're going to talk about a little bit later really comes into effect, making sure the hospital knows exactly what we've done and why and what results we've obtained. But we will touch on that a bit later as well. As we just mentioned, it is that systolic blood pressure less than 90. We want to look at what is their heart rate, how does their pulse feel, what is their skin color, all these things that let us know how our patient is perfusing. What are their respirations? Are they regular or are they irregular? How do their lungs sound? Are they breathing labored? How are they mentating? What is their GCS? All these things are those are the tools that we have in the field. So substitute the A-line and the monitors for do I have a peripheral pulse? Well, then my systolic pressure is probably around 80 or 90. So sometimes that's all you got, but those are the tools that you work with until you can get them to the truck or the aircraft for a monitor. And this was probably from my nursing to pre-hospital career switch. The biggest thing that I learned about that was kind of like, wow, why don't we do this more in the hospitals, was end-tidal CO2. What is their end-tidal CO2? And I want to take a closer look at what a great tool end-tidal is. So waveform capnography shows the measurement of end-tidal CO2. Capnography has really become a standard of care for EMS providers. We do capnography on all of our patients, whether they're intubated or just have a nasal cannula on. We have a nasal cannula that's able to read their end-tidal as well. Because it gives us such important information about the patient, it really, we utilize it on everyone. So it shows how well the patient is both ventilating and perfusing. So we're getting answers to both there. As long as the body is working and metabolizing glucose, waste products will be eliminated into the bloodstream, and those wastes can only be entered into the bloodstream if there's normal perfusion of the lungs. So if your lung isn't perfusing, you're going to start getting a buildup of lactic acid, and you'll be able to see that you're not perfusing when your end-tidal drops. So end-tidal and lactate have an inverse relationship. Keeping these patients ahead of the 8-ball means keeping them perfused. That is the most important thing us as pre-hospital providers and inter-facility providers can provide to these patients is perfusion. One more thing I'd like to touch on with end-tidal CO2, and I think this can kind of be confusing for people using end-tidal as a tool, but adjusting ventilations to either raise or lower your end-tidal. So most of you probably know, as you increase respirations or tidal volume, you will decrease your end-tidal CO2. But if you decrease your respiratory rate or tidal volume, this will raise your end-tidal CO2 values. But before we start adjusting rates and volumes, we really need to ask ourselves, why is the end-tidal low? There's really going to be 3 reasons why it's low. Are they not ventilating? Is there a kink in their ET tube or something? Something's happening where they're not ventilating. Maybe it's an easy fix, maybe it's not. Are they not perfusing, such as septic shock, or are they just dying? This is the really important thing, is we do not want to decrease our patients' respirations in an attempt to increase the end-tidal CO2 for our patients in shock. This will put them further behind the 8-ball, can cause to further distress, and could eventually lead to their demise. We always want to make sure that our minute volume, which minute volume, if you remember, is your tidal volume multiplied by your respiratory rate, is greater than 6. So normal minute volume is about 6 to 8 liters per minute. Never want to let it go lower than 6. So I just want to throw that out there because, when talking about end-tidal, I feel like this is an important thing to make sure everyone understands that minute volume has to stay high enough, that we don't want to go changing respirations and tidal volume to increase the CO2. And on a side note, patients, if a end-tidal falls below 25, and you'll notice, remember, that was part of the COTS algorithm for a sepsis alert, in the setting of shock, mortality is increased significantly. So that, I guess, is making that sepsis alert. If we're calling in somebody that's got an end-tidal of less than 25, they're in trouble. So we want to get things moving quickly. So the pre-hospital management, basically, we focus on 3 things. We've got fluid resuscitation. We'll do the 30 milligrams per kilogram. And then if that isn't bringing the patient blood pressure up to where it needs to be, or their MAP, as we'll talk about in a minute, we'll start vasopressor therapy. And then advanced airway management is something we've always got to consider also. Many of you have probably heard the saying, dilution is the solution to pollution in regards to sepsis. Well, that's what we're going to talk about first. We're going to talk about IV fluids. Again, without the fancy machines and labs, we really don't have a lot to help us determine our patient's fluid status in the field. In septic shock, we need to have continual ongoing assessment of their LOC, their respiratory status, and their vital signs to include the end-tidal. The backbone of sepsis treatment really consists of IV fluid resuscitation and antimicrobial therapy, which we obviously don't carry. So when we're doing our hospital-to-hospital transports, we just continue whatever antibiotics were hung when we started there, and if they need us to hang another one en route, we can do that as well. But that ultimately is the goal here, to get these patients started on antibiotics as soon as possible. It is recommended by the Surviving Sepsis Initiative guidelines that 30 milliliters per kilogram IV fluids be given to the patient prior to starting vasopressins. I think oftentimes we want to just scoot this in there, and the suggestion is that it is over the first 3 hours, not the first 3 minutes, which I'd say us as EMS are probably worse about that than you all are, but something to consider. And this is just a personal thing. I really didn't find this in any literature, but it was just something my medical director talked about often. You'll notice in the slide it says the pH of normal saline is 5.5. and the pH of Normal-Sol is 7.4. So after 2 liters of normal saline, I would consider switching the patient over to a Normal-Sol. Just a thought. So this is just in general. EMS will administer 500 normal saline boluses as tolerated. Of course, we're going to be maybe a little more cautious in our renal failure patients or our CHFers. But we want to titrate the fluid and the pressors according to either their systolic blood pressure or their MAP. The mean arterial pressure offers a better representation of the overall perfusion to the body's vital organs, but this would generally be included in your doctor's order in the hospital. I know our doctors always wrote, titrate for a systolic greater than 90 or a MAP greater than 65. In ours, it is set up in our protocol, so we will titrate for a MAP over 65. We talked about the first priority, fluid resuscitations. What happens when those fluids just aren't enough for keeping those patients from being hypotensive, though? Well, the next move is we have to move on to our vasopressors. Sure, most of you are probably familiar with Levocet. It had a bad rap years ago. They used to say, Levocet, leave them dead or leave the bed, because it just had, it was kind of a last-ditch effort, but it actually has turned around and is kind of the first go-to for these patients in septic shock. Often they're tachycardic already, so the dopamine isn't the best option. But this has some alpha stimulation and beta-1 for the heart rate and contractility. It is titrated at a dose from 1 to 30 mics per minute. I know where I worked previously, we did a weight-based protocol at mics per kg per minute, and many pediatric institutions, I believe, do it at mics per kg per minute. So just be advised, you might see that as well. Other vasopressor medications, there's the EpiDrip, 2 to 10 mics per minute. It has the alpha and beta response as well. You can do push dose Epi until you get your drip mixed. Epi, though, will cause an increase in your lactate level, so just know that also. Dopamine, it is an option. If your patient is able to tolerate it, it's going to be ran at 5 to 20 mics per kg per minute. But like I said, many times they're already tachycardic. And then we have dobutamine for the aid and squeeze and contractility. We're running that at 5 to 20 mics per kg per minute. Vasopressin, from what I've seen, this has kind of been the last-ditch effort. And, if they've got all these things and we still need something else, we do vasopressin 0.04 to 0.12 units per hour. And then you've got your neosynephrine as well, which is pure alpha, 50 to 200 mics. So we have lots of options there, but hopefully we can keep them ahead of the 8 ball and not have to go down that road completely. So my next goal of pre-hospital therapy, and even with the inter-facility transfers, is these people's airways. And this is where you really start to feel the intensity of the situation, especially when you're pre-hospital. You really got to ask yourself, can this patient make it through the transport, not only maintaining their ventilation, but also protecting their airway? What is their GCS? How hard are they working? Is their work of breathing adding extra demands on the cardiac system? Basically, if they're looking great respiratory-wise, we're obviously going to leave them alone. But if they're on the fence, we've really got to look at the pros versus cons of intubating each patient individually. you know, is the patient vomiting? Just all those things that you want to consider before you decide to transport a patient without a secured airway. For most of us, I believe doing airway management is probably the most stressful thing that we can do. I feel like if it becomes not as stressful for you, then it's time to probably find something else. So you may see some of us doing an airway assessment on your patients that you're thinking, well, why are they looking at their airway? They seem fine. They're not going to be tubed. It's just good practice to always do an airway assessment. You never know what's going to happen to someone. So when you see us coming into your hospitals, you might notice us looking at a Malampati or checking their the 3-2-3 rule. Can they open their mouth 2 fingers? Can I put my 3 fingers under their chin? And then do I have a space for 2 fingers between their Adam's apple and the top of their, where their hyoid bone would be? So those are just quick little assessments. Quick other things that I want to look at: do they have a beard? Is this patient going to be hard to bag? Do they have dentures? You know, what are their teeth look like? So airway consideration is the next thing that we're looking for before we transport. I think most importantly, just follow your RSI protocol. We have lots of abilities to use different drugs for RSI. I think for the septic patient that's already hypotensive, I would use a rock and ketamine. Etomidate, not only does it cause some hypotension, we usually use a half a dose of etomidate if a patient's in shock, but also it causes corticosteroid suppression. So there are better options probably than using etomidate. I just wanted to point that out. So some EMS partners have the capability to monitor finger stick lactate levels, and this could be useful for you guys to have as a baseline prior to the fluid resuscitation, just to see how the patient is reacting to that. We do not currently have that as part of our practice. I'm not sure if many of the Central Ohio EMS are doing that, if any, but I did just want to point out that some people are doing that. It might be a good thing to look into. So how can we help our patients the most? Well, like I said, most importantly, we need to do a good assessment. Look at all those things that could potentially cause problems for the patient. Know where at what status they are when you arrive to them, so that you can see where they're trending. Are they looking more and more gray as the transport continues, or are they starting to improve? Find a good baseline and work from there. Be proactive. Again, we don't want to let these patients get behind the 8 ball. The worst thing that we can do for them is to, waste time on not resuscitating them fluid-wise. Prepare for their vasodilation and their hypotensive insult. You can also see where calling a sepsis alert is it's really helpful for the patient, and that the accurate handoff information is critical to helping you guys prepare for the patient. So we work with our crews with our handout. We actually have some scripting for when we call into the hospitals via radio report. It helps us get through exactly what MIST is, the mechanisms, the injuries, the signs and symptoms, and the treatments. And so I think if we're all following that, not necessarily as a very strict, you have to say this and this and this, but as a guideline as to what needs to be included to help each other provide the best patient care, I think that's great. So why call a sepsis alert? Like we said before, it's part of your being proactive and part of your being aggressive, and that is to help initiate prompt antibiotic treatment when these patients arrive to the ERs. So a little bit more about the interfacility transports in septic shock. Like I mentioned before, we would continue the treatment that was started there. Any antibiotics, if the patient's on the vent and there's been gases done, we will leave the vent settings where they are. We're just going to continue what's been done. And we're going to ensure that the patient continues to perfuse and ventilate properly with adequate blood pressures and minute volumes, and that their end tidal stays in a range where we feel they're being perfused properly. So what makes the patient septic? This is more of the service criteria. This is, hospitals can do these sort of things because they have lab values, right? So that's where these things come in handy. This is if the temperature is greater than 100.4 or less than 96.8, the heart rate's greater than 90, respiratory rate's greater than 20, and then added here, different from the EMS side, is the white blood cells greater than 12,000 or greater than 10 bands, so or less than 4. So you can see how it's a little bit different, but really very similar as well. This is the CMS definitions of sepsis, and this is kind of reminds me of the SOFA chart that we looked at earlier. You know, does the patient have these, again, labs, so this is more of a hospital thing, but do they have these signs and symptoms? And if so, we're going to call them severe sepsis. And if they have these, a lactate greater than 4 and persistent hypotension after 30 milliliters per kilogram of crystalloid, we're going to call them septic shock. So just a little slide to point out the differences with CMS and pre-hospital definitions. So when we come to your hospital, we have a lot of questions. Some of them may seem silly, but it's just really so we can get a good idea of what's going on and then in turn be able to give the nurses at the receiving facility answers to the questions that they might have. So we're kind of being proactive and assuming the questions the nurse at the receiving will have. Is the source of the infection known? Do you already have blood cultures drawn, and have you already been giving antibiotics? If so, what antibiotics and how much? Does the patient have any allergies? How much fluid has the patient received, and how has their blood pressure and heart rate been trending? Again, we're just looking to see perfusion and kind of get an idea of where we need to start our resuscitative pattern. What was the patient's white blood cell count, electrolytes, creatinine, and lactic acid? Just giving us an idea of their infection and their fluid status and acidosis. Do we have an ABG? What are those results? And do we have any relative CT results? Meaning maybe the patient has a dead bowel or something that's causing their sepsis. And then what initially brought the patient to the hospital? What was their chief complaint? And does the patient have a significant medical history? Again, the things like CHF that might affect the way that we give them fluids rather than start the vasopressor therapy. And then a little bit about missed handoff. I think most of us here in Central Ohio are using this. Cox has rolled it out to us, and it's been a great tool for us to use to make sure we're hitting all the key points of report and handoff. So the M stands for mechanism. We want to know what was the cause of the injury or the illness. The I stands for injury or illness. What was the sustained injury or illness found? What injury or illness did you suspect? The S is for signs and symptoms. What physical signs of injury or illness is a patient displaying, and what are the symptoms that the patient describes to you? And the T is treatment. What treatments have been administered, and what medical care do you provide up until the handover in the ED ICU? So we want to be sure to tell them what meds we gave. If we did change the vent settings, we want to be sure to pass that off. Certainly if we intubated the patient, we want to pass off which drugs we used for the intubation. So these are all really important things for the physicians and the nurses to know at the bedside at the receiving so that they can, make the best treatment options based on what's already been done. There's one more part of the missed handoff that sometimes you might hear it called DMIST, and where the D stands for detail. And the detail is essentially what is the patient's chief complaint, what is their age, medical history, allergies. I think that's a little bit more really of what we give at the hospital because we do want to give you guys all that information too. But we are certainly open to feedback on what could make the process better. I know Survival Flight and myself in particular, we love feedback. It might be a good thing if the sepsis coordinators could get in touch with the EMS coordinators to be like a liaison to EMS and give some feedback on the care they provided to the sepsis patients in the field, and then we can make improvements based on that. But I did want to say thank you for having me today. I've enjoyed being here. I wanted to tell you a little bit about our company. We are located on the north and south side of Columbus. We operate 2 Bell 407 helicopters. We fly with a flight nurse and a paramedic. Dr. Scott Dunn is our medical director. And we love to do outreach, so if anybody needs us to bring our aircraft and come see some nurses or doctors, we'd love to. So thank you.
Well, Amanda, thank you very much. This was certainly a phenomenal presentation with really a lot of information from the clinical perspective. At this point in time, I would like to invite our listeners to submit their questions through our question and answer box or chat line. We do have several questions that have been submitted already. I know that you started off the presentation, Amanda, talking about leveraging the tools that you have available in the air that may not be the same tools that nurses and physicians have in acute care settings. And so relying upon physical assessment skills, vital sign measurement, and that kind of thing. You also talked a lot about the very important eyeballing and airway assessment and considerations that you do when you're going to a hospital to transport a patient to another facility. And I think many times we don't consider that because in hospitals it's more of a controlled environment. But you mentioned things like hair growth, beards, the ability to intubate, is there enough space, that kind of thing. And I think those are wonderful perspectives for us to hear from your world and your perspective, because we don't always consider that on our end. So thank you very much for that.
Yeah, thank you.
Our first question that has come in states, we are in a lower socioeconomic and rural area. Are there any programs or grants or contracts to help us obtain capnography for the areas that do not already have one? I think a good goal would be to have access to this machine on each run. So that's the question. Are there programs, grants, or contracts available to help obtain capnography equipment?
So I would be curious as to what kind of monitor they have. I know the Zols and the Life Packs and the Pro Packs all have a place where you can just screw in. It's essentially just like a plastic line you screw in. It's disposable for each patient to the monitor, and that's how you get your end title. But most monitors already have that option on them, so it would just be a matter of buying the tubing.
Okay. Thank you.
And I don't know of any grants, but I would imagine there are.
Okay. The next question is, the caller wrote, love the information, but just missed the information regarding the administration of vasopressor, being the last pressor to use. Could you please explain?
Yeah, so vasopressin, it just seems like, from my experience, what I see is if someone has to be on multiple pressors, so they'll be on Levophed, and then, they may add dopamine, then they may add neosynephrine. It seems that the last one that they add typically is the vasopressin. And that's just from my experience. I don't know that that's part of any protocol or anything. It just seems to be the line of the way the physicians handle that.
Okay. Our next question is, what do you think some of the opportunities are for building trust between EMS and hospitals?
I think that's a really good question, and feedback is a really good one to know, that we either did the right thing or we didn't do the right thing, but that we now can do the right thing the next time, I guess, is helpful. I think anytime you can bring those people in to do education together with the hospital staff, that also is a really good opportunity for EMS and hospitals and people in the acute care setting to get together and have a little bit of fun, but still be learning at the same time. I think it's really about building relationships. So if you can take that minute while your EMS providers are in your ER and just say hello, maybe explain to them what they're doing, maybe show them something that they probably don't get to see. All that's really exciting for them. So I think that's just a couple ways that could be done.
Thank you. The next question is kind of interesting. The caller wanted to know what percentage of hospital transfers are actually related to sepsis. That's an interesting question.
It is, and I don't have the exact numbers of that, but several. We actually do quite a bit of interfacility septic transfers. You know, you get these outlying hospitals and these patients are in the ICU and they just get to a point where, you know, they just don't know what to do with them anymore. So, or they're being proactive, which was part of our slide, right? And they're saying, we know that this patient's going downhill and they probably, you know, they see their bands are really high and they're thinking, oh, they're going to get worse. So let's go ahead and get them out of here somewhere where they can be more aggressively managed. So, and I don't know the percentage, but I do know that it is actually quite a bit.
Okay. Our next question is, has there been any discussion about obtaining blood cultures for sepsis patients in pre-hospital care or carrying antibiotics on board? And I think you had mentioned in your presentation that you don't initiate antibiotics, but you continue them. Is that correct?
Yes, yeah, that is right. We don't carry any antibiotics. So for anything that any sepsis patient we'd pick up in the field, it would be just like if EMS were to bring them in. No treatment would be started. But yeah, we would definitely continue from the interfacility, whatever they had hanging. Good question and good point about the blood cultures. I was actually talking about that with someone the other day because, you know, they do the blood draw for stroke. And I was thinking it would be a really good idea actually to do the blood draw for sepsis. Of course, it would take some education because sterile, you know, getting all the scrubbing and stuff for the blood cultures in EMS would be a little different for them. But, you know, through a little education, I think that actually would not be a bad idea at all because we all know we can't start those antibiotics until we get those cultures. So if that could be done prior to them getting to the hospital, that's a great idea.
Thank you. Our next question is a comment and a question. The caller writes, I'm not a receiving hospital typically, but a sending hospital. And we don't usually get feedback on the patient's outcome. How can we do this?
I know, that's a challenge. So we don't get feedback either, typically. You know, where I flew at before, it was a hospital-owned program, and so the benefit of that was you got to follow that patient through their stay, so you knew exactly what happened their entire time. But here, since you know we're not owned by a hospital, we drop off to anywhere, I guess is what I'm trying to say, that we don't get feedback from anywhere. So I don't really know. I think the best way to get the feedback, if you really wanted it, you would probably have to call the EMS coordinator where that patient went, and they would probably more than likely be able to get you that information. You know, if they can validate it and being an educational tool, you know, there's the whole HIPAA thing. So I think it's going to depend on their comfort level and, you know, why you want to know and that sort of thing as well. But that is an option. Call the EMS coordinator at whatever facility that patient was dropped off at, and they may be able to get you at least some general information.
Okay. The next question is, what is the most common age range of sepsis patients that you transport?
You know, I really haven't transported any septic kids that I can recall. Of course, we have Nationwide Children's Monarch here, so they probably do a lot of the inter-hospital pediatric calls. We do more scene pediatric calls. But I would say, for me personally, probably in the 60s, 50s, late 50s, the 60s age seems to be the most popular.
That's very interesting. Okay. The next question just says DMIST versus SBAR. Can you comment?
Yeah, so I think they're both tools to help us make sure that we're getting off the appropriate information when we hand off to someone. Yeah, the DMIST is very similar to the SBAR, just you know, more in the EMS world, we're going with the MIST handoff, and you guys in the hospital world are going with SBAR, but very similar. Both just really wanted to pass along that accurate information and make sure that certain features aren't missed in report.
Okay. And the last submitted question that we have is, what is most critical to receive in a report, and should it be from a physician or a nurse?
I think all of us are absolutely fine with getting a report from the nurse. The only benefit sometimes of the physicians giving the report is oftentimes the nurse hasn't got a chance to look at the CAT scan results or something like that. So usually the physician that has that information at the top of his head, but the nurse always knows, you know, exactly how much fluids were administered, what the patient's urine output was, all those little details. I feel like really the nurse would probably give a better report. But I would say doesn't matter either one. And the most important bits of information in terms of sepsis is, I believe, how much fluid has the patient received and what is their medical history, because I don't want to keep pushing fluids on someone and, you know, cause more damage. So, you know, and then just that, you know, what was your baseline assessment on this patient, I think is most important.
Okay, thank you. Well, that concludes the questions that have been submitted. We certainly appreciate your time and your willingness to share your expertise with us, Amanda, and I certainly appreciate all of the audience and participation from our callers today. We do want to make an announcement about the May webcast. It will be on the third Wednesday as always, which is Wednesday, May 15th. Our topic for the next webcast will be maternal sepsis. For this particular program, though, there will be a change in the time. Instead of 11:30 a.m., the broadcast will be at 2:00 p.m. Eastern Standard Time, and it will be a 1 hour and 30-minute program rather than a 1 hour program. You will be receiving in your inbox an updated calendar invitation along with some information. Registration for that particular program will be required. Obviously, there is no fee. But the reason for that is we are co-providing this presentation with Sepsis Alliance. So you'll be hearing from a physician, a nurse, and a maternal sepsis survivor who will tell her story. So again, mark your calendars for Wednesday, May 15th at 2:00 p.m. Eastern Standard Time, and you will also be receiving a calendar invitation to that effect. And as always, we encourage you to invite whomever you feel from your institution that can benefit from this information. That is the goal of providing this type of continuing education. Another reminder, please be sure to complete your evaluation by accessing it on the link provided at the beginning of the program today, and that will ensure that you receive your continuing education certificate. Having said that, this concludes today's webcast. Again, thank you, Amanda. Thank you all for joining us, and have a great day.